Without new treatments or innovations or ways to prevent or delay Alzheimer's and dementia, the number of persons living with this disease will be about 12 million by 2050.
From the USC Leonard Davis School of Gerontology, this is Lessons in Lifespan Health, a podcast about the science and scientists improving how we live and age. I'm Professor George Shannon, Kevin Shue Chair in Gerontology. On today's episode, how Professor Julie Zissimopoulos is exploring innovative ways to ease the burden of Alzheimer's disease. Julie Zissimopoulos is an associate professor in the USC Price School of Public Policy and the co-director of the Aging and Cognition Initiative at the USC Schaeffer Center for Health Policy and Economics, where she's also a senior fellow and the director of two NIA-funded centers that support innovative social science research on dementia. She recently spoke to us about her research using economic insights to better understand the impact of Alzheimer's disease on individuals, families, caregivers, and society. Hi, can we begin with my asking you to put Alzheimer's disease in a kind of demographic context for us? How prevalent is it today, and what are the projections for the future?
Sure. Thank you, Dr. Shannon. So we have approximately 6 million Americans today living with Alzheimer's disease and other dementias. And to put this in context, this is 2 million more than the population of the second largest city in the US, which is Los Angeles, where we are. The prevalence of Alzheimer's and dementia, that is the number of persons who are living with the disease today, is in part a result of the success in combating disease. People are living longer than ever. So, for example, today about 50 million Americans are age 65 and older. It was about half that in 1950. And by 2050, U.S. Census projects about 20% of the U.S. population will be 65 and older. And age is one of the foremost risk factors for Alzheimer's and other dementias. So what does this mean for our future? Well, it means that without new treatments or innovations or ways to prevent or delay Alzheimer's and dementia, the number of persons living with this disease will be about 12 million by 2050.
I understand that Alzheimer's is not an equal opportunity offender. Can you explain the disparities in terms of who's at most risk for the disease?
So as I mentioned, age is an important risk factor. And there is early onset, that is before age 65, that affects about 200,000 Americans. But the risk of Alzheimer's is really a risk at older ages, and it rises dramatically with age. So for individuals 65 to about 79, about 7% of them will have dementia. But in your 80s, the risk of dementia is about 20% prevalence. And by 85 and older, if you live that long, about 40% of those persons will have Alzheimer's. It's also much higher for women than men. And that difference is not explained just by the longer lifespans of women compared to men. It's also about 1.5 to 2 times higher for Blacks, Hispanics, American Indians, and Indigenous Americans compared to whites. And we know a little bit about what explains some of the differences by race. Some of it's explained by education and prevalence of chronic conditions that are associated with higher risk of dementia, like hypertension and diabetes. But it does not explain it all. So other research is looking into early life social and economic factors, environmental exposures, such as pollution, which our colleague Tuck Finch is looking at, social factors such as loneliness and gene and environment interactions, such as our colleague Eileen Crimmins is looking at. And then an area that I'm working on, which is disparities are also potentially arising from the drugs that we're using to treat our chronic conditions that are not Alzheimer's and dementia related, such as diabetes, hypertension, hyperlipidemia, or high cholesterol.
So how can these pharmaceutical treatments for common health conditions like diabetes or hypertension impact risk and disparities in risk?
Well, there's a couple of ways that we hypothesize these drugs might be impacting dementia risk. So the first is they might be reducing risk of dementia by reducing the risk of the condition that they're approved to treat. So for example, the use of antihypertensives to reduce blood pressure, statins to reduce high cholesterol, anti-diabetics to reduce the impacts of diabetes. And all of these diseases, hypertension, hyperlipidemia, diabetes, are all associated with increased risk of dementia. But there's also another way in which these drugs might be acting to reduce dementia risk, and that is by acting directly on AD pathology. That might be acting on inflammation in the brain or in the amyloid plaques that are characteristic of Alzheimer's disease. And the use of these drug treatments are very common. About 66% of older Americans use 3 or more pharmaceutical drugs. And the use of these have been increasing over time. So, for example, the use of statins for high cholesterol has increased by almost 70% between 2000 and 2012. So we are looking at which of these drugs that are used to treat these chronic conditions might be able to reduce risk and for whom. So this might be through initiating treatment or improving adherence. We also know that there are some drugs that are associated with increased risk of Alzheimer's and dementia. For example, there's mounting evidence that anticholinergic medications might lead to higher ADRD incidence. And so our approach has been to look at real world evidence. That is, we're using data from Medicare claims. So all the medical and drug claims of all the Medicare beneficiaries in the US. And the advantage of taking this approach is that we have really large samples of different populations. So we can look at the use of drugs in different racial and ethnic groups and the risk of Alzheimer's and dementia. Because once you're a Medicare beneficiary at age 65, your medical claims are followed all the way until your death.
So there are currently no known treatments for Alzheimer's disease, but are there still benefits to early detection?
We do believe that there are many benefits to early detection, and let me just name a few of them. So first off, cognitive impairment may be an indication of dementia, but it also may be treatable. It may be due to reversible causes. Early identification may allow management of cognitive symptoms. There are several approved drugs that can improve cognitive performance, at least in the short term. Early identification may also allow to better manage the comorbid conditions. So many persons living with dementia also have other comorbid conditions that they're managing, like diabetes. But I think really importantly is thinking about planning for the future. So with a progressive disease with no treatment or way to prevent it, it's important for families and individuals to be able to plan for their future, financial planning, connecting to services for themselves and their caregivers, protecting themselves against financial scams. And it also allows the opportunity to participate in clinical trials if they're appropriate. And I would like to say a few comments about policy, because there are a few policy opportunities to improve our ability for early detection, but it's not clear that they are achieving their policy goals. So with the Affordable Care Act came a new Medicare benefit, the annual wellness visit. And this is a comprehensive primary care visit that requires, among other things, that the healthcare provider detect for cognitive impairment. And unfortunately, when the annual wellness visit benefit was first introduced, very few eligible beneficiaries were using it. So about 10% were. But today, about 50% of our Medicare eligible beneficiaries are having an annual wellness visit. But we were interested in understanding the cognitive assessment aspect of the annual wellness visit. So we collected data from a nationally representative sample of older Americans to understand better their use of annual wellness visit and the cognitive assessment. And what we found that was only about a quarter of them who received an annual wellness visit also reported receiving a cognitive assessment. And this was higher for beneficiaries who were in Medicare Advantage type plans versus those who were in the traditional Medicare plans. And this might have an important indication that these traditional benefit plans, the Medicare benefit plans, where there's direct service-related payment for a set of bundled services, like at the annual wellness visit, may not be a very efficient way to increase our cognitive assessments. We also, I think, have some opportunities to improve our policy around cognitive assessments. Right now, there's no guidance about what constitutes a cognitive assessment or how it should be performed. So a clinician can use a structured tool, which we have many of, or they might just ask the beneficiary, the patient, if they're concerned about their memory. And so all of these factors may affect whether we are actually providing good early detection or not.
So over the course of these podcasts, we've spoken to several scientists doing research to understand the biology behind Alzheimer's. Why is it also important to understand it from an economic perspective?
Well, along with the incredible health toll that Alzheimer's and dementia takes on person and their families, it also takes an incredible, tremendous financial toll on the person who's living with dementia and their family. Alzheimer's disease leads to cognitive decline, slowly destroying the brain functioning. It also leads for many to behavioral and psychiatric disorders and declines in ability to self-care, functional status. And all of this is extremely, extremely costly. So we estimated the costs for all the persons with Alzheimer's disease, all their medical care costs and long-term care costs. And it's about $200 billion. But that's only a portion of the costs. So as I mentioned, persons with dementia need a lot of care, and much of this care is provided by family members, unpaid care. And if you value the hours of family members' caregiving, that's about $100 billion. So we're talking about over $300 billion in costs of care for dementia. And this is more than the cost of cancer and heart disease combined. To think about it at the individual level, a person with Alzheimer's disease, their costs each year are about $70,000, 4 times higher than an otherwise equal person without this disease. And these costs that I'm talking about, the healthcare, the long-term care costs, and the value of unpaid caregiving by family members only begins to account for the costs. It's not accounting for the costs of adult children who become caregivers, their loss of productivity in the workforce, loss of income. There are many other costs associated with dementia outside of these very large costs that I just spoke to you about.
So you're able to quantify the burden of the disease on families and also on caregivers. Is that true?
That is true. And while we value these costs with the numbers that I provided, I think it's an underestimate. There's other types of costs, as I mentioned, those having to do with work, productivity, and potential loss of income and wealth due to being more susceptible to financial scams that we have not yet quantified.
Well, we talked earlier about disparities and who's at risk for Alzheimer's and dementia. Are there also disparities in how the care is provided?
Yes, we've been studying care for persons living with dementia and differences across racial and ethnic populations. We found that racial and ethnic minorities are more likely to have a delayed diagnosis of dementia after experiencing cognitive decline. We also looked at who is receiving dementia specialist care. And although very few people overall are receiving care by dementia specialists, it's even lower in racial and ethnic minority groups. And racial and ethnic minority groups are less likely than whites to be treated with drugs that treat their cognitive symptoms. These are acetylcholinesterase inhibitors like donepezil and some of the others.
What are some of the impacts of unpaid care on family members and caregivers?
There is a growing literature that is looking at what are these impacts on the unpaid care provided by family members and other caregivers. And there's very consistent evidence that there is negative health effects, particularly on mental health. Caregiving for a person with dementia, particularly as the disease progresses from mild symptoms to severe, is a very stressful type of caregiving. There's a very long arm of financial impacts. For spouses, wealth is consumed to pay for long-term care. So care in a facility such as a nursing home can cost anywhere between $50,000 to $100,000 a year. And most families don't qualify for Medicare that reimburses for the cost of long-term care. And for adult children who are caregivers, there's impacts on their work productivity, their ability to maintain work in the labor force, on their income. And we don't have, as a nation, national family leave policies to support and pay for time away from work for caring for older family members with dementia or other conditions.
So how does paying for all this care impact our healthcare system today and for future generations?
Well, the numbers are staggering. We project that if there is no innovations in treatment or prevention, the cost of Alzheimer's disease will reach about $1.5 trillion in 2050. To put that in context, this is about the GDP of Canada a few years ago, according to the IMF. We don't know the impacts of innovations in treatment, although there's been some hopeful innovations recently in the news. But if the innovations in other disease are guides, they are likely to be expensive, albeit valuable.
So what policy changes do you think are necessary to address long-term service and support?
Well, I think one important policy change is we need solutions to support family caregivers in the workplace, compensation programs. But this isn't going to be enough. Demographic trends suggest that family caregiving as the main source of care is likely not sustainable. People are having fewer children, and there are more Americans with dementia. So we really need an insurance system to cover long-term care. The current system does not function well. People who take it up tend to only be those at high risk with very high healthcare costs. So we need to be a little innovative here. Maybe consider a voluntary auto-enrollment in long-term care insurance with an opt-out, much like what has worked well in the retirement savings market. Medicare could also help, like we had new benefit of Part D that covers drug expenditures and protects against very high out-of-pocket spending for those beneficiaries with high drug expenditures. This was very successful. Medicare could do something similar for long-term care, but it will be very costly. So we will need to figure out who will pay, how we will finance this, and who is going to bear the costs of this. Will it be the younger generation through taxes on, say, health insurance premiums? If so, how are we going to make sure that they don't bear the full burden?
Well, on a personal level, I understand the benefits of delaying onset of the disease. What are the societal benefits from an economic perspective?
We've learned a lot about brain aging over time, despite the not successful clinical trials for drug development, although we're making progress there. But I think what's important to understand is that we don't need a home run to have an economic impact. So my colleagues and I modeled what a 5-year delay in the onset of Alzheimer's disease would mean from an economic and health perspective. And we found that a 5-year delay would result in about a 40% reduction in the number of Americans living with the disease in 2050 and about $600 billion in savings.
What are your future goals for your research?
Well, I'm very interested in continuing to try to understand how drugs for our chronic conditions are affecting our risk of Alzheimer's, looking at anti-diabetics right now and some of those drugs that are potentially increasing risk of Alzheimer's and dementia. I've been working on understanding and reducing barriers to early detection, how we might improve that and have some real impact there. And then there are many policy changes that are happening to Medicare, new benefits in Medicare Advantage, and these could all impact the care and quality of life for persons living with dementia. And it's important for us to understand what care systems best serve the needs of those individuals, protect against financial impacts for them and their families.
Well, I think it's clear how Alzheimer's disease and other forms of dementia can affect ourselves, our families, and the society as a whole. Is there anything else that you'd like to add?
I guess I'd just like to end by saying that social science has a lot to offer in terms of identifying opportunities to reduce risk, reduce disparities in risk, and improve quality of life and care, and really reduce financial burden. And at the USC Schaeffer Center for Health Policy and Economics, and in collaboration with the School of Gerontology, we have 2 NIA-funded centers that support grant awards and mentorship opportunities for social science scholars who are interested in this area of research. And through efforts like this and growing this area of research, I think we can make immediate impact while we hopefully wait for clinical development of that drug that everyone is hoping for.
Well, thanks a lot for your enlightening discussion. And I think it's going to give a lot of substantive information to people who listen to this podcast.
Thank you, Dr. Shannon. I enjoyed our conversation.
That wraps up this lesson in lifespan health. Thanks to Professor Julie Zissimopoulos for her time and expertise, and to all of you for choosing to listen. Join us next time for another lesson in lifespan health, and please subscribe to our podcast at lifespanhealth.usc.edu. Lessons in Lifespan Health is supported by the NIA Center for Health Span Science and the Center for Lifespan Health.